You can hear me properly. Okay. So welcome everybody to this interesting session. My name is Jocelyn Young from the Faculty of Health Sciences at the American University of Beirut. I'll be the discussant for the three papers, and I believe we're going to start with this paper, which is an innovative combination of health and population data with climate data. And addressing the question of does climate change affect child malnutrition in the Nile Basin? So over to you, Amira. Thank you very much.
Thank you. So good morning, everyone, and thank you very much for organizing this session. It's my pleasure to present this joint work with Hala and Ronia Hawash. So changes in climate will make many countries in the next 30 years experience more heat waves and also more extreme weather events, including both droughts and floods. And we are already experiencing this. So such changes in climate have great impacts on humans' health in general and children's health in particular. So these impacts can happen directly through the emerging of water or airborne infectious diseases, or indirectly through affecting the agriculture production negatively, which would lead to increases in the prices of food and agriculture products, and would also at the same time affect the income levels of those working in the sector. So all these factors will definitely affect the nutritional quality and the quantity of children. And according to the WFP, climate change could increase hunger and the child malnutrition in the next 30 years by 20%. And of course, the low-income countries and the poor populations will be less capable of confronting the adverse effects of climate change on children's growth. And therefore, studying the impacts of climate change on children's growth in the developing countries, and especially in Africa, is very important for better assessing the risk of malnutrition associated with changes in climate, mitigating its effects, and distributing the available resources efficiently. Black et al. In 2013 concluded that low and middle income populations have relatively the highest rates of stunting among children worldwide. Stunting is only one form of malnutrition when a child has a low height for age. There are other forms of malnutrition like wasting or underweight, but here we focus on stunting due to its bad impacts on the mental and the physical growth of the children, and also because its impacts on health are largely irreversible. But of course, other forms of malnutrition can be considered in future work. And according to Davenport in 2017, because most of the African developing countries are highly dependent on subsistence agriculture, they will be the most vulnerable part of the world to food insecurity and children malnutrition, which is also exacerbated with the changes in temperature. But the impacts of climate change are not always the same. They differ from one country to another and also within the territory of one country due to the geographic and population heterogeneities. And therefore, in our study, we aimed at examining the association between climate anomalies and malnutrition among children below the age of 5 at the subnational level of 3 Nile Basin countries. These countries are Egypt, Ethiopia, and Uganda. We have mainly chosen these 3 countries because they are different with respect to their climate characteristics, their geographic distribution of population, and also socioeconomic characteristics. We are not just investigating the impact of climate change on children's growth at a smaller spatial scale, but also we are examining the impacts of the surrounding and the socioeconomic characteristics of the children's on the children's growth and health. Another aim of the paper was to try to produce a map for the geographical distribution of below 5 child stunting across the spatial domain of each of the studied countries after controlling for the variability that can be due to the differences in climate and socioeconomic characteristics. So all the analysis was implemented using an advanced geographical regression model that is fitted in a Bayesian framework, which is very efficient at investigating the differences and similarities across space. In our study, we relied primarily on data from the latest available DHS data of the 3 countries for the height, the weight, and the socioeconomic data of the children. One advantage of the DHS data is that they are geocoded, so we know the position or the location of each household and, of course, the children in this household on the map. And then for the climate data, we have obtained monthly time series for the temperature and the precipitation from 1951 to 2015, or just to the year prior to the DHS in each of the countries, from an archive data set that covers the whole Earth at a resolution of 0.5 degree by 0.5 degree. And these data are based on statistical interpolations from a very large number of weather stations across the globe. The next step was to try to match these climate data to the DHS children data. And because the DHS data are geocoded, so we were able to do this match. But how we did the matching? So we identified the geographic position of the DHS cluster, or it means the child on the map. And then we have drawn a circle of 10-kilometer radius around this cluster. And then we have averaged the temperature of all the grid cells that intersect with the drawn circle within this 10-kilometer buffer of the cluster. But why 10 kilometer? We have used this 10 kilometer radius circle because this is the maximum displacement that has possibly been done to the DHS unit to preserve its privacy. So that by this way, we are trying to minimize the bias that may be coming from this displacement. So in terms of the variables we have the stunting, which is our response variable. And that's a binary variable that takes the value 1 if the child is stunted relative to the WHO standard. And the primary covariates of interest are the average temperature and the precipitation deviations from the historical data that a child may be exposed during his life prior to the year of the DHS. And more details on the calculations of these variables are presented in the paper. We are not just, as we mentioned earlier, we are not just investigating the impacts of climate, but also a range of other variables that belongs to the child or the mother of the child and the household where the child live, in addition to the historical temperature and precipitation for the location or for the cluster for the area where the child live. So all these data were modeled as per this model, or as per shown in this equation here, where the log of the odds ratio for stunting is modeled as a function of the different socioeconomic and climatic covariates of the child. And the difference between this model and all the standard linear models is that the random part is now divided into 2 components. So one component is responsible for accounting for the spatial variations in the stunting status that may be originating from the spatial dependence as usually, close observations in space would tend to be more similar than far away ones. So for example, if two children lives very close to each other, so if one of them is stunted, there is a high probability that the other one could be stunted as well due to some shared spatial dependence rather than far away children. So this is accounted for by this component here. The other component, so that's the spatially unstructured component, and that's the usual independent random error that would account for any variations that is not explained by the other terms in the model. Without getting into too much details of how the model is fitted, the parameters of the model are mainly estimated using a Bayesian framework. That is highly efficient and that is computationally efficient as well. The results of this model indicated that the odds of stunting are higher among the males in the 3 countries, and that the education level of the mother and her nutritional status are two covariates that have significant impacts on the nutritional status of the child in the 3 countries. But the wealth status, for example, was only significant in Ethiopia and Uganda, but not in Egypt. There is also no evidence for a significant urban-rural effect in the 3 countries. And this might be because the effect of the place of residence have been mapped in other variables in the model. And you can observe that the risk of stunting increases with age. And this is quite logical, as we tend to discover more stunted children as the child grow up. For the climate variables, we found that the deviations in temperature were higher than the deviations in precipitations. And for example, in Egypt, we found that both the temperature and the precipitation deviations from the average over the course of the life of the child can have significant effects on the stunting status of the child. So this is in the sense that as the average temperature anomaly increases, the probability of stunting tend to increases as well. Whereas for the precipitation, there is more like an L-shaped relationship in the sense that stunting probability tend to increase with dry spells. And this can be justified by that with dry spells, there might be reductions in the agricultural production. But it is not yet clear what is happening as the child witnesses more rainfall than average, as there is more uncertainty in this part of the relationship. For Ethiopia, the precipitation was the only significant predictor, but not the temperature. And the relationship between the probability of stunting and precipitation anomalies takes an inverted U shape. And maybe it is not very clear here, but if you zoom in, you will find that here there is, if you zoom in on the scale, you will find that there is a decrease here as in the probability of stunting with increases in the deviations and in the anomalies of precipitations over the course of the child life, implying that this might be associated with changes in with more or better agricultural production. In Uganda, it seems that the stunting risk increases with increasing temperature and decreases with increasing rainfall. However, these impacts of climate deviations on the child nutritional status were not significant. And these are the geographic distribution of stunting in the 3 countries, and you can see that in Egypt the hotspots are mainly in the north, in Gharbiya, along to Cairo and maybe Fayoum, whereas in Ethiopia the odds of stunting are higher here in Amhara, which is well known with bad nutritional status of children, and this south part of the country. And for Uganda, it's mainly also the south or the southwest of the country that is suffering from high stunting rates. So in conclusion, the results indicate that the climate change has definitely impacts on children's health and growth, but it could be different across different countries. It is not always the same impacts. The impacts of climate on children malnutrition doesn't happen in a single direction. So it's not that decreases in precipitation is always associated with high stunting rates. And that within each specific countries, there are regions that are more vulnerable to children malnutrition and changes in climate, which even can be exacerbated, where the climate change can even exacerbate the situation there, and hence these regions need more attention. At the end, we can say that these results would aid in cluster level planning, which would then improve the allocation of the limited resources to the clusters with high needs of healthcare. And the future work is now involving studying how the effect of climate may vary from one location to another. And these are some of the few references that I have used in the paper and in my presentation today. Thank you very much for listening.
Thank you very much, Amira, and a very interesting paper. I am going to be responding to the papers, but I think it's best that we hear from all three presentations in the interest of time, and then I will address the comments at the end.
Okay, thank you.
So I think we'll go next to let me see, the paper by, just seeing which order we should do this in. Should we do the paper on Tunisia next by Khaled Nasri then?
Mm-hmm.
Khaled, are you ready?
Yes, okay. I will share my screen with you now.
Great.
Yes, it's okay.
We don't see it yet.
Yeah, okay. Yes.
It might take time with the internet. Just try again.
Yeah.
And just a reminder that each of the speakers has 15 minutes for their presentation. That's perfect. We can see it now. Thank you, Khaled.
No, it's good, no?
Perfect. Great.
Yeah.
Please go ahead.
Thank you, Professor, and good morning, everyone, and welcome to my presentation. First of all, I will let me introduce myself. I am Khaled Nasri from Tunisia, researcher at the Faculty of Economic Science and Management of Tunis, and the researcher associate at Economic Research Forum. So the title of the presentation, as you can see on the screen, the impact of job loss on mental health during the COVID-19 crisis, evidence from Tunisia. And before starting, I would like to mention that this work was co-authored with Dr. Abdallah and Dr. Fethi Amri. So this presentation is organized as follows. I will begin by giving you a background information on the topic and the objective of our study. Then I will move on to our empirical strategy. Next, I will discuss the main results, and I end with the conclusion and recommendation. So, to slow the rapid spread of COVID-19 across and within countries, many governments responded with strict measures, including lockdown with border closure, restriction on travel, and school and workplace closures. These measures resulted in a significant rise in empowerment in many countries. In this regards, the International Labor Organization estimated that working hour losses in 2020 were approximately 4 times greater than those during the global financial crisis of 2009. So for many people, job loss means not only the loss of income and financial benefits, but also a loss of identity. Hence, it can also be a major reason why they may experience symptoms of depression more than those maintaining their status in the labor market. So it is recognized that in addition to economic costs, the health costs of COVID-19 are not limited to physical health, and but include the effects of the pandemic and restriction on people psychological well-being. So Tunisia, like most countries, used various measures to prevent the spread of COVID-19 across the country. And once the disease circulates, governments are forced to adjust their strategy to reduce the burden on the health system. On 22 March 2020, total population containment was imposed on Tunisia for 2 weeks, and it was extended twice. The lockdown made the job research more difficult or impossible in certain cases, and many workers lost their jobs. Big word about the indefinite duration of this disease was associated with severe symptoms of depression, and it is therefore understandable that people have experienced fear and depression in the context of the pandemic. In this research, we aim to investigate the impact of job loss on the mental health of individuals in Tunisia during the COVID-19 crisis. So in the first part, we calculate mental health indicator for all individuals included in the sample. The individuals were then grouped into two sub-populations. The first group included those who had lost their jobs, and the second groups included individuals whose status in the labor market had remained unchanged. In the second part, we used the Blender and Oaxaca decomposition to explain the main difference in the mental health scores between the two groups and determine the factor contributing to this difference. So we used in this research Tunisian data taken from the ARF COVID-19 MENA Monitor Household Survey filed in November 2020. The sample universe for the household survey comprised mobile phone users aged between 1864. The survey covered demographic and household characteristic, education and children, labor market status, income, social safety net, mental health, and social distancing. The survey asked for the labor market status in October and collected retrospective data on labor market status in February 2020. So the mental health of individuals was measured using the WHO 5 items questionnaire that tap into the subjective well-being of respondents, and which was introduced in the survey question in the mental health model. So the mental health indicator and symptom of depression are measured using a short question consisting of 5 sample items that tap into the subjective well-being of respondents. The first one, the item number 1 is I have felt cheerful and in good spirits. I have felt calm and relaxed is the second item. The third item is I have felt active and vigorous. Item 4, I wake up feeling fresh and rested. And item 5 is my daily life has been filled with things that interest me. Each of the 5 items is scored from 5 all of the time to 0 none of the time. The mental health scores ranges from 0 to 25, where 0 represents the worst possible mental health, and 25 represents the best possible mental health. So if individuals scored 0 to 2 on item 1, they were considered in a depressed mood, B1. They were categorized as having decreased energy, B2, if they scored 0 to 2 on either item 3 or 4, and as having loss of interest, B3, if they scored 0 to 2 on item 5. We assume that individual suffered from a mild depression if they manifest syndrome B1 or syndrome B2 and B3. We consider those with the syndrome B1 and B2 or B1 and B3 as people with moderate depression. Conversely, depression is considered severe if people had all three syndromes, B1, B2, and B3. Individuals were grouped into two subpopulations. The first one, denoted L, include those who had lost their jobs. The second group was denoted now lost an L and included individuals whose status in the labor market had remained unchanged. So estimating impact of job loss on mental health using the blender and the Oaxaca decomposition to explain the main difference in the mental health score SE out. It's the mental health score SE is our outcome variable between the two group 1 and group 2, and determine the factor contributor to that difference. We model it separately in group 1 and in group 2, a linear relation between variable of interest SE and its determinants. We note S bar and as the means of explained variable in the two groups. The main outcome difference can be expressed as the difference in the linear prediction of the group specific means of the regressors, and the main difference in the mental health scores differ from one group to another because the characteristics are not the same. This is explained part, component, and unexplained component measure the discrimination between two groups, that is difference in treatment that is only due to belonging to one group rather than the other. So this difference can be assimilated into a causal effect, and empirically the average treatment effect can be estimated by the unexplained component resulting from the decomposition of blender and Oaxaca. So in the labor market outcomes transition between February and October 2020. So as shown in the table, 85% of individuals working in February 2020 in public and private sector maintained the same status in October, and individuals who had lost their jobs represented the 11%, and which those who had switched to another states represented 3.11%. So the in our sample, 37.75% had overall mental health scores lower than the main population score estimates at 60.9%. This rate varied according to the socio-demographic characteristic of individuals. So there was a slight difference between the rate of men and that for women. This rate varied considerably depending on the age group. It exceeded 44% for people aged between 50 and 64. Also the highest rate among individuals living in large families, and this rate decreased each time the level of education increased. Our results show that 30% of individuals had a depression mood. The second symptom was decreased energy, the highest rate of which were for men, people aged over 40, and individuals with less than basic education level. So in like the other two symptoms, loss of interest was more common in those aged between 30 and 39 in married people and those living in household of one or two people. Based on these three symptoms, we classify people as having three types of depression. Our results show that of those in the sample, 31% suffered from mild depression, and the highest rate were among men, those aged between 50 and 65, married people, and those who did not have a basic education level. The same, we estimate that 20% of people had moderate depression, and women being the most affected. The lowest rate were for unmarried people and those living in a family of no more than 2 people. We found that also that 4% of people had severe depression. The highest rates were among living in large families and those with less than basic education level. So as the figure shows, all the mental health indicator of individual who had maintaining their status were significantly better than for those who had lost their jobs. More than 40% of individuals who had lost their jobs had mild depression. This rate was estimated at 30.3% for those included in the second group. We estimated also that more than a quarter of the first group had moderate depression, and about 5.5% had severe depression. However, these two types of depression affected 20% and 3% of individuals in the second group respectively. So to understand and explain this difference, we used the Blender and Oaxaca decomposition. In the table, we represent the decomposition output, which reports the main prediction by group and their difference in the first panel. So in the sample, the main mental health score was 17 in the second group and 50 for the first group, yielding a score gap of 1.88. In the second panel, of the decomposition output, the score gap is divided into 2 parts. The first part reflects the main improvement in the scores of the individual in the first group if they had the same characteristics as those of the second group, and the difference observed in the stability of households and account for about 80% of the explained part of the outcome difference, whereas the other variable do not seem to matter much. The second part quantifies the change in the scores in the first group when applying the coefficient estimated for the crude model to the first group characteristic. So this is explained by the difference in the characteristic of the 2 groups can be attributed to the fact that they belong to one group rather than other. In other words, it is the average effect of job loss on the mental health of individuals in the first group. So as conclusions, in this study, our findings have shown that 3 in 10 people were in depression mood between October and November. Decreased energy symptoms were present in 4 in 10 people, and particularly those aged between 15 and 64, and those with less than basic education, regardless of their age. Compared with other symptoms, the lost interest symptom was not dominant during the crisis, and age and size of the household can influence mental health, and having a higher level of education can strengthen people's resilience against mental effect during the crisis. But we have not been able to observe that mental health indicators constantly differ according to sex or marital status. So by applying the counterfactual decomposition technique, our results show that there is clear evidence that the instability of household income caused by job loss has significantly contributed to the worsening of individuals' mental health. And by decomposing the difference in main scores of the 2 groups, now evidence shows that age, household size, and fear of the country's economic situation can explain the difference observed between the scores of individuals who had lost their jobs and those who had maintained their job status. This difference is mainly due to the household income stability variable, which is in turn is strongly linked to the protection of employment status in the labor market. These results can call into question the effectiveness of social measures and the decision taken during this period of crisis, in particular the aid granted to companies, to firms, to encourage them to keep their works. So from this analysis, several policies are recommended other than financial aid to encourage firms to keep their works. Psychological support policies intended for vulnerable groups such as elder people and those with low level education should have been implemented. There is an urgent need to establish a job loss insurance system, and informal workers are encouraged to participate in the social security system to receive benefits in the event of job loss or old age. Finally, thank you so much for listening.
Perfect. Thank you so much, Khaled, and also thank you for sticking to time. Very interesting paper. And so last but not least, we're going to turn to the third paper, which is also using the same sources of data. And this is a paper by the other Amira El-Shala, and her colleague Eman Moustafa. So now we look forward to hearing from you. Thank you very much. I'll let you know when we can see your presentation.
Hi, everyone. Okay, let me try share my presentation.
It's starting. Yep, we can see it now.
And by the way, the other Amira, we graduated from the same class. So I'm glad that I'm glad that we are joining this session together.
Yeah, it's my pleasure.
Yes.
Amira,
okay.
you just need to put it on presentation mode, yeah?
Yes, 1 second, please.
That's perfect. We can see it clearly. Thank you.
Thank you so much for pointing this out. So, so I'm glad to be among you here today to present joint work with my friend and colleague Eman Moustafa. We have been trying to bring together the mental and like the psychological and economic factors affecting preventive health behavior. And this is like this, our work is under development, so we are very much looking forward to the discussion and to any suggestions or like concerns raised by any of the participants. So our paper is titled "Feeling Blue Over the Economy Will You Pull Down Your Face Mask? Preventive Health Behavior, Psychological Well-Being, and Economic Anxiety." So to give you a little bit of background, we are all aware that non-pharmaceutical interventions are very important to contain disease outbreaks, especially when we are at the early stages of an outbreak. We have seen this with SARS. We have seen this with the Ebola outbreak in Africa, and we have seen this widely actually during the first stage of the COVID-19 pandemic. Non-pharmaceutical interventions are very much important because we didn't have a vaccine in place, so people have to abide to wearing a mask, to clean their hands, to keep or to maintain physical distancing. And these three preventive health behaviors are among the most cost-effective precautions that should be adopted by populations, especially at the early phases of an outbreak or a pandemic. And we have all seen that more than 120 countries worldwide mandated the wearing of face masks in public to contain the first wave of COVID-19 pandemic. And still, while like some of these mandates have loosened, we are still seeing these protocols or these mandates effective in a lot of countries, and they are still effective in many countries in the MENA region. Among the countries that mandated the wearing of face masks in public are Egypt, Morocco, Sudan, and Tunisia. But unfortunately, the enactment of a public health preventive measure does not necessarily imply compliance. So we have seen it in Egypt that, okay, we have this face mask mandate, but still people don't necessarily abide and don't necessarily involve in preventive health behavior. And governments try to use various tactics such as fines to enforce the favorable measures. But at the end, we emphasize that it's individual rather than government action is what counts in the battle against pandemics. So here we are trying to tackle the issue of preventive health behavior and how can we kind of promote preventive health behavior. And like surveying the literature, we have seen that disease risk perception dominates research on the determinants of preventive health behavior. So basically, when people like feel that there is like they are more vulnerable and susceptible to being infected with a disease, they usually go and adopt a preventive health behavior or comply with a preventive health measure. So it all like mostly depends on disease risk perception, how people perceives the risk of this disease and how people perceive their vulnerability and their susceptibility to being infected with that disease. But unfortunately, less is known about how the public perceives the risk associated with a disease outbreak. And also the literature on preventive health behavior is dominated by risk perception, but little is known about how mental health affects engaging in preventive health behaviors, and the evidence is mixed so far. Also, and this is like where we are trying to bring the focus, economic anxiety has become more salient than health anxiety over the course of COVID-19. So we are trying to shift the discussion from like focusing on the health aspects of preventive health behavior or like the health determinants of preventive health behavior to the economic determinants of preventive health behavior. And we have seen that it's imperative now to study how different economic factors can promote or discourage preventive health behavior, shifting the discussion from like risk perception and the traditional determinants of preventive health behavior from the health side, trying to bring to the fore the economic determinants of preventive health behavior. And studies to date have focused on how socio-economic status can predict general preventive health behavior, but we haven't seen recent studies focusing on the economic, focusing heavily on the economic dimensions and how different economic factors can actually affect the likelihood of engaging in a preventive health behavior. And using the MENA Monitor household survey data, we have tried to plot changes in preventive health behaviors in the MENA region from November 2020 to August 2021. And the figures actually were worrying because we have seen that, for example, in a country like Morocco, we have seen that people are becoming like more relaxed and less likely to maintain physical distancing, being outside their homes. And this applies to wearing masks in Morocco, and also to washing hands with soap in Morocco. So we are seeing, or like we are detecting some relaxation from people's side. They are trying to feel less worried. They are feeling less worried about being infected with COVID-19. So they are basically, in some countries, people are less complying with preventive health measures. And we are also seeing a great heterogeneity. So for example, in a country like Sudan, physical distancing and wearing masks is very much, or like are very much less being reported compared to Egypt, Tunisia, or Morocco. And this is important not just because we are like in the context of COVID-19, but we are aware that like weather and health disasters, or like the occurrence of weather and health disasters, is increasing over time. And it's not just about one pandemic, COVID-19, but in light of the climate change and other challenges, we are more likely to face more health disasters in the future. So we need to know what's going on when it comes to preventive health behavior, because we will be needing this to face future health disasters in the region and even like worldwide. So the main objective of this paper is to examine what determines the uptake of preventive health behavior in the MENA region in the context of COVID-19, and to bring to the fore economic and psychological determinants. So basically, we'll be focusing on the effects of mental health, specifically psychological well-being, but we will also, or we are also bringing to the table the economic determinants as key determinants of the likelihood of complying with a preventive health measure. And when we are mentioning economic determinants, we mean economic anxiety, changes in consumption or changes in food consumption, and also labor market or labor market status. And we also would like to shed light on what other determinants contribute to the prediction of non-compliance with COVID-19 preventive health measures in MENA, because at the end, when we know who are like the populations who are more likely to not comply or to not adhere with preventive health measures, we can guide MENA policymakers to tailor the public health policies toward these populations in order to to have a higher compliance with preventive health measures in the future. And to do this, because like the individual decision to adopt a preventive health behavior is kind of complex. We have a lot of factors that can kind of influence the likelihood of an individual adopting a preventive health behavior. And we all know that an individual's decision to adopt a preventive health behavior and her or his subjective well-being can jointly be affected by several factors. So an explicit example is the risk perception, how an individual perceives the risk to catch COVID-19. This will jointly affect preventive health behavior and will also affect the psychological well-being of an individual. So we developed this generalized structural equation model to integrate the causal links between psychological well-being and the uptake of preventive health behavior in a recursive framework. And we hope that this framework handles the indigeneity of the psychological well-being preventive health behavior relationship by including a common unobserved component into the two equations here. And we are also confident that this framework accommodates the selectivity of reporting psychological well-being for only a subsample of our individuals. To probe deeper into these two equations and like our main variables, here PHB is a binary variable for an individual, like an individual eye reporting adopting a preventive health behavior. And here PWB is a continuous subjective psychological well-being index, which we constructed using multiple correspondence analysis. We also have the R, which is a core, like a fundamental determinant of preventive health behavior, which is the risk perception, or how an individual perceives the risk of COVID-19. And we included the Z vector, capturing a lot of like confounding demographic and socio-economic factors, and also the neighborhood effects. So this is like our first equation, which basically shows that an individual decides to adopt a preventive health behavior as a result of her or his psychological well-being, along with other determinants. And then in the second equation, we show that an individual's psychological well-being during COVID-19 is determined by his COVID-19 like risk perception, but also depends on, or like is determined by a vector of economic determinants that can affect psychological well-being, and consequently or recursively will have an impact of the likelihood of adopting a preventive health behavior. And we focus here on two main determinants. economic anxiety, and food consumption change. We also are thinking of including labor market status here, like bringing it out from the vector of socio-economic determinants and including it in the economic vector to kind of feature how economic factors, or to highlight how economic factors can have a tremendous impact on preventive health behavior through affecting psychological well-being. For our data, maybe I can mention this shortly because Dr. Khaled already referred to this. So I'm using the ERF COVID-19 MENA monitor household survey data, and for the sample coverage, I'm using the four North African countries: Egypt, Morocco, Sudan, and Tunisia. Our sample size consists of more than 5,000 individuals, which were interviewed in at least 2 waves, and our time framework spans from November 2020 to August 2021. And these are our our variables in our system of equations. So for our main dependent variable, it's preventive health behavior, and we capture it by 3 measures: physical distancing, wearing masks, and hand washing, or washing hands with soap. And we have this endogenous variable, which kind of is present in our 2 equations: psychological well-being. And in order to reduce our data, the dimensionality of our data, we have constructed a psychological well-being index using the 5 questions that are available in the MENA monitor household survey data. Other explanatory variables that we are including in our analysis, the main one is COVID-19 risk perception, and it's the core or the fundamental variable in the health belief model and in all other key health behavior models. We are also including economic anxiety, neighborhood effect, a lot of economic and demographic factors. Maybe for the sake of time, or for the interest of time, I can skip and go straight forward to the results. So this is the estimation of the estimation results of our first equation, which is what determines psychological well-being. And we can see here that consumption change and economic anxiety have a significant effect on psychological well-being, even more than COVID-19 risk perception, which is the main the main factor, or the main determinant that is dominating the literature. But we provide evidence here that economic factors ranging from economic anxiety, consumption change, or food consumption change has a significant effect on psychological well-being. And we can observe this in Morocco, we can observe this in Sudan, and we can also observe this in Tunisia. So this is the results of our first equation. For our second equation, we are trying to see, okay, now psychological well-being, preventive health behavior is affected by psychological well-being. What are the other determinants that are affecting the likelihood of engaging in a preventive health behavior? And we can see here that psychological well-being plays the strongest role affecting the likelihood of physical distancing. Again, COVID-19 risk perception has a significant but less significant role, and also the neighborhood effect or neighborhood compliance plays a significant role, and we can observe this in fact in all our countries. And here we are referring to physical distancing, and we reran the estimations for another preventive health behavior, which is wearing masks, and the results are not very different. And also for hand washing, and here we can observe less significant results when it comes to psychological well-being. And our understanding is that this may be because hand washing is a less publicly visible practice in fact. So people will not observe you if you washed your hands or not, but they will observe you if you are wearing a mask or if you are maintaining physical distancing. And we will probe deeper into this because we think like the variability or like the heterogeneity in the results will bring about a very interesting discussion. So, so here are our main results and conclusions. We show that through affecting psychological well-being, economic determinants can actually impact preventive health behavior adoption. So it's not just COVID-19 risk perception, but economic determinants can also impact preventive health behaviors through affecting psychological well-being. Our estimates reveal heterogeneity in individual responses to different preventive health behavior determinants across countries and by behavior type. We observe that psychological well-being has the strongest effect on the likelihood of physical distancing in Egypt and Sudan, and of wearing masks in Morocco, Sudan, and Tunisia. This psychological well-being is in turn affected by changes in food consumption and economic anxiety in all 4 countries. We also observe that hand washing, which is a less publicly visible practice, is affected by COVID-19 risk perception, followed by neighborhood compliance. And also gender, age, education, and labor market status effects varied across countries and by preventive health behavior type. And finally, and this is the part we are trying to expand at this stage, we observe that labor market status is particularly relevant for unpaid family workers in Egypt and Sudan, and employed in Egypt, Morocco, and Tunisia. Our key policy implications focus on how to mitigate the negative effects of an outbreak on consumption changes, to provide to strengthen household resilience when it comes to consumption fluctuations, and to consider labor market status, focusing on the unemployed, focusing on those unpaid family workers. So considering or addressing, considering those groups could kind of help promote preventive health behaviors. Also addressing mental distress and economic anxiety during public health crises can help increase the likelihood of engaging in preventive health behavior. And we are trying to bring to the table the importance or the relevance of public communication strategies, and how these public communication strategies can kind of influence risk perceptions among populations. And we are also bringing to the table from the nudging or the behavioral literature, how can kind of MENA policymakers or MENA governments use nudging, especially with groups that are less likely to comply. How can MENA governments use nudging to increase their compliance, etc. So I think I'll stop here, and I look forward to your comments to improve our work. Thank you so much.
Thank you, Amira and Eman. Thank you. That's really a rich presentation and discussion. So thank you very much for that. So I am going to kick off the discussion just with some comments, and then we'll open it for other people to raise issues. So I first of all wanted to thank all the speakers. I'm going to make comments in the sequence in which they were the papers were presented. But I just wanted to say it's been really interesting to hear the analysis of health, which is my field, from these different perspectives and using really rich and innovative sources. So, of course, the last paper that we heard and Khaled's paper relied on the COVID monitor, which is a very rich panel data, panel surveys conducted in different countries in the region. And it's really nice to see that data analyzed and how useful it is, but particularly in assessing change. The other paper that I'll talk about now is also very innovative in its use of data sources, because it draws on population health data from the demographic and health surveys, and then climate related data. So I'll talk about that in a minute. But before I give my comments, I just wanted to lower your expectations of my comments, in the sense that I am not an economist. So I'm a public health specialist. So my comments will be more from a health perspective than an economics perspective. Okay. So with that said, let me now address the paper by Amira, Hala, and Ronia, I think. does climate change affect child malnutrition in the Nile Basin? So this was a really interesting topic and a very timely topic, looking at climate change and the health of children, particularly nutritional status of children. And it was also innovative in the choice of countries, so focusing on the Nile Basin countries, Egypt, Ethiopia, and Uganda. And one of the great things in reading this paper is it's informed by a really strong literature review and background section. And it points out that there's a lack of data, particularly on this question for low and middle income countries. A lot of the research has been done in high income countries. And it makes a strong argument for why we should zero in on malnutrition and why we should look at children who are particularly vulnerable to the effects of climate change. And what another strength of the paper is that while focusing in on nutrition at the individual level, it looks at some of the larger level factors related to climate change, for example, food production. And I really like this figure 1 that it shows in the paper and that you also showed in your presentation, which kind of is a conceptual framework for how climate change could affect children's nutritional status. I assume that this was your work and that was your conceptual framework. One of the things that I was struck though in looking at that is it doesn't seem to factor in sort of child feeding practices of the household and of the mother. So for example, it doesn't look too much at breastfeeding, and it also doesn't look at young child feeding practices. So I thought that those, while of course disease and food availability are critically important, those intra-household factors are also very important, and I didn't see those as much emphasized. Also, in terms of food production, we know that in famine situations, it's not just the availability of food, and this is the work of Amartya Sen, which is of course very important in this area, that it's not just the availability of food at an aggregate level, but critically its distribution and access entitlements to food. So that was another area that I thought maybe could be incorporated more into the analysis. So, as I said, very innovative combination of this use of demographic and health survey data with the indicator being stunting, defined as having a height for age, Z score less than a -2. And then this very valuable data from the University of East Anglia Time Climate Research Unit's time series, amazing data from 1951 on climate temperature and precipitation data, going back all those years. And a very impressive large sample of children, 22,000 children altogether. And the methods were very carefully written up. And so, very nice to look at this and to look at the anomalies, climate anomalies, and comparing them to findings in the literature. And as it was pointed out in the presentation, it's also nice to look at and useful to look at the regional, which regions stand out in each country after controlling for the various factors. So, and it's interesting that in Egypt, the areas that seem to be to have to stand out were Fayoum, Sharqiya, and Sohag. In Ethiopia, the Amhara region, which of course is a region that's been subject to many natural and man-made factors, as well as conflict, and I'll come back to that. And then in Uganda, the Southwest. So some of the questions for discussion or just comment, I wasn't clear, and maybe the authors could explain about this. In the case of Ethiopia and Uganda in particular, we know that climate change is also often associated with sort of forced displacement and population movement. And I'm wondering how that is captured in the surveys. So I wonder if the authors could comment about that. And then, in terms of the conclusions and the kind of policy recommendations, and this is something that I think is relevant across all three papers, is sometimes I found that there was a kind of simplistic understanding of the determinants of health. And so sometimes the recommendations would come back to, these regions are clearly facing a problem in terms of child malnutrition or whatever else other outcomes one was looking at in the other papers. And therefore, there's a need for more health care. And I just wanted to point out that, of course, in the public health field, we're very cognizant of the fact that healthcare, access to healthcare is only one very small part of the whole determinants of health. And increasingly in recent literature, we're talking, at least the last decade or so, we're talking much more about the social determinants of health, the way in which people live as being really the biggest, and live across their life cycle, the way they work, their housing conditions, those are really the largest determinants of health. And I think that's what you're really addressing in your research. But then when it came to the policy of recommendations, it came back to the health sector, when in fact, the health sector, again, is only one small part of the, the policy response to these issues. So again, a very innovative combination in this paper of, of data and of the kind of issues that you're looking at. So very interesting paper to look at. And so thank you very much for the analysis. And I look forward to hearing from the authors in response to the wider discussion. So I'll turn now to the paper by Khaled, Nasri, and colleagues from Tunisia, Mohamed and Fethi, I guess. And again, a very timely issue of looking at the mental health stresses associated with COVID, and particularly relating to the loss of job. And again, the paper was very well researched, and I welcome the fact that it drew on a literature not only from the region, but also globally. And it points out that much of the literature on the mental health relating to COVID has been focused, certainly in this region, on the mental health of healthcare workers and not of workers in general. And by using this COVID monitor data, the authors were able to use this scale developed, I guess, by the WHO, a 5-item scale that you saw the questions relating to, which in turn derives from a larger 10-item scale, and in turn from a larger 28-item scale. So as you saw, the main questions are relating to being cheerful and in good spirits, being calm and relaxed, active and vigorous, waking up feeling refreshed and rested, and daily life being filled with things that interest. I guess one of the things that occurs to me is that these are all items that, we all know that during COVID and the ups and downs with lockdown and social isolation and all the factors that related to COVID over its 2-year period now, that these are items that are likely to vary a lot over time. And so I think that this would be one thing that would be useful for the authors to discuss, because certainly, when you look at some of these items, as we experienced COVID and as we came in and out of lockdown, these were like to be very dynamic. The other point that I wanted to make on this paper is, and maybe I misunderstood it, but the focus seemed to be only on loss of job rather than loss of income. So of course, loss of job was seen to be associated with the loss of income. So and the paper found very significant findings in relation to household loss of income. But so my question is, so in fact, the percentage of people who lost their job was around 11%, and 3% changed their job status. But we know that many people could keep their job but lose income, and particularly where the informal sector is dominant. And so this is where I wanted to understand more about the labor market in Tunisia. But I would have thought that many people, for example, worked in transport and tourism, so may have kept their job but lost their income. So for example, even in the professional level, we know that dentists and doctors kept their job but significantly lost income. So how did you bring that into the analysis? And then I thought it was a very interesting finding that you actually didn't emphasize so much in your presentation, but that the public sector workers, not surprisingly, there seemed to be more job protection. I would have liked to have seen that analyzed by gender. I didn't see much gender analysis in that paper. And then I think also a comment for the other paper that I'll talk about in a minute by Amira and colleagues looking at preventive health behaviors is in using the COVID monitor, I didn't see much critical analysis of who is missed in that survey. So the survey, of course, relies on mobile phone users. These are people aged 18 to 64. I would imagine in both countries where this data was used, Egypt and Tunisia, there are many people who don't have a mobile phone, who maybe wouldn't have been reached for one reason or another. And again, there may be gender issues here. So I would have liked to have seen a little bit more emphasis in your limitations on who is missed. And I guess the last comment I would make on the paper on Tunisia is that mental health is a very complex outcome. And the emphasis in the paper is on sort of loss of identity and economic factors. But of course, we know that mental health is really very multifactorial. And so I would have liked to have seen, a more acknowledgement of that complexity of mental health in the discussion. Okay, great. So now I will turn to the paper by Amira and the other Amira and colleagues, Precautionary Health Behavior in MENA, Amira and Eman, sorry. And I think this is again a very interesting paper and makes use of this innovative COVID monitor panel data. Very impressive size of the panel, 17,000 households in 4 countries over the period November 20 to August 2021. It zeroes in on those who responded twice, at least twice. So I think in the paper it was 6,459 individuals, but I noticed in the presentation and the new analysis, 5,000 about 5,300. What I liked, one strength of the paper was definitely that it drew on theoretical models of health behavior change and risk perception. And this, we know that in disease outbreaks in general, risk perception is really important. And in fact, the paper, very much shows that being worried about how much you're at risk of getting a COVID-19 was a huge determinant of your likelihood of adopting precautionary behaviors. But the colleagues also did a very good job of saying, but that's not, of course, your risk perception isn't in isolation of the economic factors. And so they try and factor in both the health anxiety, your perception of getting infected, with this economic anxiety. And in the findings, we clearly saw that the economic anxiety is actually critically important in how much you're going to adopt some of these health behaviors. Again, the paper was really well researched and very clearly written, and the methodology was really clearly described. In terms of some of the comments I had on the paper, so in the paper, it said the likelihood of wearing a mask in Egypt, and again, this is drawing on the analysis in the paper, in Egypt was not affected by risk perception, mental health, or neighborhood compliance, and this warrants further investigation. And I guess reading the paper initially, I would have liked, especially since the researchers are Egyptian and based in Egypt, for there have been more analysis from your own understanding of the Egyptian context as to why that might be the case. So just to leave it at that and not sort of explore what the factors might be, begged further questions. And then the individual level factors which were focused on in the paper, of course, are critically important, but this is not to throw out the sort of more macro level policy questions. And I was struck by the wording that you said that the individual rather than government action is really what counts. But of course, the two are very interrelated. And so it's still very important to understand to what extent did the government actually enforce some of these measures and communicate them. And so, although I know it's not the subject of your paper, that the COVID monitor and this kind of data does allow us to compare across countries and over time and look at whether governments were actually doing their job. And as a public health person, this is very, very important. I also would have liked to see more analysis across social class and age. And eventually, one has the possibility to combine this data with now much more epidemiological data. For example, one could look at uptake of testing and later vaccination and link these kind of conclusions. So again, very interesting paper, and so I think that concludes my own comments, and hopefully we have another 15 minutes or so to open the floor for wider discussion. So anyone got a comment that they would like to raise before we give the authors a chance to respond? Yeah. Don't see any comments. Is that right? Let's open the chat as
No.
well.
We don't have any comments.
Okay. Okay, so we have about 15 minutes left. Shall we go to the first paper then, the climate change paper, and see if the authors have any comments?
Yes, thank you very much for the valuable comments, which is definitely enriching the paper and can enrich as well the discussion around the paper. So some of the comments that you have raised, I think these are very good points to discuss even in the conclusions or the recommendations part of the paper. So these things will definitely be taken care of, and we are going to try to enrich the discussion more by shedding the light on these points, and like the access to healthcare. That's the smallest portion of the public health, and yes, maybe we have to talk more about the determinants or the social determinants of health, and talk about this in the policy implications part of the paper. For the population movement comment, I think that's a very interesting comment that maybe we haven't thought of when we were developing the model for the data that we have. But I think this would need another source of data because that's related to disasters or weather disasters that is happening in those countries. So we might need like another source of data and trying to see whether the people were forced to leave some locations to another location, and to have been disrupted, like their living status has been disrupted by these things. But we have in the paper, or in the data that we have used, we have tried to examine what the climate has done to people living in the same place for a long period of time. So that's one point that we have kind of addressed in the model, and focused on, maybe not from this the same perspective that you are talking about, but we have considered that this might be a reason for leaving the place, and that's why we have just focused the model on the people living in the place for a while during the study. The other comment, I think, about not including variables like breastfeeding or access to food, things like these variables. We have thought of including these variables in the model, as of course they have very big impacts, and we should also control for them in the model. But the thing is that in the data we are considering children from 0 to 5. So there is here that status where there are children that are in the status of being still breastfeeding, or even they are still at the very early stages of getting the milk, whether it's bottle fed or breastfed. But then we have these children that already has passed this period. So it was kind of, okay, we don't know how we should involve this in the model. But one of the things that we have decided to do maybe in the future is to try to model these or to try to repeat or replicate some form of the model, but on children just up from 2 years old up to later ages, and make a model separate to those children who are at the very early month of after birth. So that could be one way of accounting for this, for these variables that are, of course, of great importance, but it's just a matter of what variables that can go for both or for all children in the study. That was the main determinant of what variables to include in the model. But yes, definitely, this also maybe needs to be pointed out even in the discussion, so that it is not left open like this. So it just leaves maybe the impression that this hasn't been considered or hasn't been looked at. So I think I have replied to most of the comments. And thank you very much again for all your valuable comments. I think they will definitely enrich the discussion around the paper. Thank you very much.
Great. Okay. So Khaled, you want to respond to the comments? You're muted, Khaled.
Well, thank you so much, Professor, for your valuable comments. Yes, if I well understand, it's the point to focus on the income decrease in the impact of income decrease on the mental health. In our paper, we focused on the impact of job loss, and we have found as a result that the impact of mental health on the impact of job loss on the mental health is this difference between the two groups is mainly due to the instability in the income of individuals, which mean the decrease of income. But in the survey, which I have the chance to participate with the ARF team for waves, in this paper we try to neutralize the effect that individuals keep their job with decrease in income, and to neutralize the effects of policies and taken by the governments to encourage firms to keep their jobs, their works, and to do that, we have just looking for the impact of job loss and explain this difference between by characteristic, and we have shown that this difference in the mental health scores is due mainly to the instability of variable of income. Yes, we will try to include more discussion about this point in the final version. And thank you so much for your comments.
Thank you, Khaled. Thank you very much. So Amira, the other Amira, back to you.
Thank you so much, Professor Jocelyn, for Jocelyn, for all the useful comments, and they are all make perfect sense to me. When it comes to the limitations, we definitely would have to include a section or a subsection in the discussion, focusing on the limitations of the data set we are using. So on the one hand, the data set is very innovative and it's very kind of novel or fresh, provides fresh evidence. But on the other hand, we have to provide a more thorough description of the data, and to say that, okay, we are missing the elderly, we are missing children, or so this would be we will definitely do this, and also we will also definitely add more discussion on based on our understanding from the concept of our understanding of the context in the MENA region. So we'll try to see specifically when it comes to hand washing, because we didn't find a significant effect of psychological well-being on hand washing, and it's only driven by risk perception, which gives rise to the a discussion that, okay, in the MENA region maybe we do care about how people think about us rather than doing the thing the right way. So we will definitely probe deeper into this, based on our understanding of the concept of the context. Also we try to think of ways how we can include data on government actions or government mandates and the enforcement thing and the communication thing. We have data from the Oxford Tracker, and we used it in another country level analysis study, but here we couldn't kind of include it in the analysis, and we know that it's very important that you can have the mandate but you are not communicating it well, you can have the mandate but you are not enforcing it. So maybe if we didn't find a way to include this, maybe we can add it also to the limitations that we need kind of a future further investigation, because we believe that me myself, when I got vaccinated, I felt that I'm stronger, so I didn't wear the mask the same way I did it before. So definitely we'll try to see how can we include this, maybe it's a kind of fixed effects, it's included in the model in a way or another. We will try to find a way. And also we'll try to expand the analysis on the age, because we already have it in the model, but we include it as one of our control variables. So we'll definitely would like to expand this discussion based on your suggestion. What we would like to consult you, and we are happy that you are from the public health background, not from the economic background, is what you find more interesting, because basically when we were trying to frame the questions of the study, we first were focusing on risk perception and neighborhood compliance. So these were our two area of interest. But when we surveyed the literature, we found that there are tons of studies on risk perception, and also our estimation results, the one that are updated, kind of shifted our attention to the economic factors. So we moved a little bit from risk perception and neighborhood compliance, which are included in the model, but we shift the discussion from them, focusing on the economic determinants, specifically unemployment, food consumption change, and economic anxiety. So included these three as economic determinants that can shape preventive health behavior through affecting psychological well-being. So we would like to take your advice about what's the best way to frame our research questions, because we have this data and we have this analysis, but from your perspective, what do you think would be the most interesting when we are trying to feature or highlight our estimation results? Interesting for public health specialists and for policymakers. We would love to hear from you on this in particular. This is our deficiency. Thank you so much.
Thanks a lot, Amira. So I would just say that I think it's really innovative and important that you addressed both the risk perception of disease transmission with the economic anxiety and how those interrelate. Because I think in public health, we tend just to, sort of factor out the economics and just think about the risk perception. And of course, people do not compartmentalize, right? They will weigh the risks of their daily life. And, and we know, looking at this region, that the risk of losing your job, that what Khaled addressed, and losing your income and economic insecurity, food consumption changes, those are critically important to your well-being and to your feeling of agency to try and prevent the epidemic. So I think linking those two is a real strength, and to me that's more interesting than the neighborhood side of it. I think that's a really novel comparison. The other thing is, I think it would be interesting to look over time, because I suspect at the beginning of the pandemic, when we didn't know how severe it would be or how long it would last, the risk perception about the disease transmission might have been higher, right? That might have been the dominant really risk fear. And then over time, as we started to see people losing income and jobs, and then we all adapted, and we maybe so maybe over time the economic kind of factors started to weigh more than the risk of disease transmission, and especially now that it's so protracted, right? So it became a 2-year, basically. We're not out of it yet. So yeah. So I think it's very interesting, and again, it shows the importance of economists working on health, and that's why I was really happy to see all these papers. Okay, so I think we're bang on time. So really interesting, and thank you so much for your hard work on these papers. And I look forward to seeing them in publication and taking them to the next step. So thank you so much, and good luck with everything.
Thank you very much.
Thank you very much. Thank you.